Test, good? Very good. All right. So, we now have 2.5 hours left, and we have to write a paper together. So we promised Bonnie that she would get a paper for her research question, and we only have 2.5 hours left. So, while you guys were having lunch, Kristin and I were feverishly working away to take the design that we all agreed to before lunch and to try to see if we could run that across the OHDSI network. So I'm just going to talk you through briefly exactly what we did so you understand the process. So when we finished earlier, where we were, there we go. Go back to here. For those of you who are still in Atlas, you can follow along again here. Where was we? User 1. I was going to say many of you were following along, which is great. So this is what we had created together. We had Bonnie's prediction question, predicting lymph node metastases in patients with endometrial cancer. And I showed you how, when you're on the utilities, you can actually see exactly all of the analyses that you've specified. And where we left it was that you downloaded a piece of code. That code is a package that anybody in the OHDSI community can run on their own computers to produce results. So what exactly is that package? Well, I'll just open it up here so you can see. So that package, it's a little bit hard to see there, is a series of folders and files. But most importantly, it's an R package, meaning that it's code written in the programming language R that is set up to be able to run this statistical analysis. R is the open source programming language we primarily use within OHDSI that anybody can use to run. But basically the way that it runs is you open up a program called RStudio, which is this program here. And in this folder that I've created here called Fudan 2019 PLP Bonnie, I've just put the files that are contained in that program. And one of the files is called code to run. And code to run is the only file I have to change in order to run this code against my data. So I opened up the code to run file. And I had to make a couple changes to make it work in my environment. I had to tell it where I was going to save my results. I had to tell it a place where it could do its analysis. I had to give it connection details to connect to my database so that I could run this analysis against my data. I had to specify the name of the database that I was going to run, the name of the table that I was going to create to contain the results, and then I had to execute the analysis. So I grabbed this code and I ran this code while you guys were at lunch. And that's what Kristin and I were doing while you guys were having a little bit of a break. And so you might be interested in what happens when we run this execute file. And so you can see there are a set of parameters that are parameters in this code that you have to decide what do you want the program to do when you're running the analysis. So I'll just talk to you about some of the things that this program can do. one of the first things that it does is it can create the protocol. So remember, we described that one of the most important parts about doing science is to fully pre-specify your analysis by writing a protocol that describes exactly what you want to do. Well, this program will write the protocol for you if we just say create protocols equals yes. So in fact, when I ran it, I did, here's your first result, Bonnie. Whoops. I did produce the protocol for this analysis. We ran a patient-level prediction study, which I called Fudan 2019 PLP, Bonnie. But what does this protocol contain? It contains all of the sections that you would expect to have in a document that describes all the steps that we were going to follow to do the study. You can see that in the executive summary, it tells us that our objective of this study was to develop and validate a patient-level prediction model for 2 different target cohorts. We had the Bonnie's cohort, which is endometrial cancer with the additional inclusion criteria. And we added an additional criteria, which we talked about privately this morning, which was people who've had a hysterectomy for endometrial cancer, so that we could look at the people who are also treated for the disease. And we're going to predict 2 outcomes. We focused on Bonnie's primary question of interest, which was secondary malignant neoplasm of the lymph node. But also to perform an additional analysis, I also thought that it would be good to look at all secondary cancers. Because if I'm a patient with endometrial cancer, probably the most important thing to me is, am I going to get some other kind of cancer in the future? So we added that as a little extra to see what would happen. And we performed this analysis using Bonnie's 2 different time at risk windows. The first one was a time at risk from 14 days to 365 days. And the second one was from 14 days to 1,085 days. So that's our 1-year window and our 3-year window. This protocol document that is automatically generated provides you little helpful hints of where we think you probably should write some extra language to explain, for example, here, a rationale. We're recommending that you, Bonnie, are going to write a short description about why is this question important to you. So we're going to give you a little placeholder, and you can just add in a couple sentences to tell us why you think this is an important question. The protocol is automatically written, though, to tell us what are the prediction problems that we're going to solve, and you can see them listed out here. It then goes through and describes the entire methods that we are executing in this study. So it's describing that we are doing a retrospective observational patient-level prediction design. It defines what prediction is. It provides our standard picture that you see and some appropriate references. It provides us a section where we're going to be able to describe which data sources are participating in this study. And that's important because when we post this protocol to the OHDSI community, we don't know who is going to volunteer to participate with us. So this provides us a placeholder that anybody who says they'd like to participate, we can add them to the document as we go along. So you already have 2 volunteers for your study, Bonnie. I'm volunteering to participate, and Kristin's volunteering to participate. So you've already got 2, but you'll probably get many more once we post this onto the OHDSI forums. And the reason why people in the OHDSI community are going to be interested to do this study is because they'll be able to read this document and see exactly what it is that you are trying to do. So they'll be able to see exactly what were the cohort definitions that you used, and exactly what were the outcome definitions, and exactly what's your time at risk. And here are all of those population settings that we filled in that form to do. They're now all being shown in the document, so everyone knows exactly what's happening for this study. You've got a description of how you're performing lasso logistic regression is one of your algorithms. And you're also describing in this protocol exactly what outputs we intend to produce. So we know we're going to look at discrimination, and we know we're going to look at calibration, because those are our best practices that we discussed this morning. We've described all of the code that we're using and all of the diagnostics we've run, and the entire data analysis plan is fully specified in this document. It's actually quite a lot of stuff, lots of decisions that we had to make, which it didn't seem like it took us that long, but in fact we made many, many dozens of decisions along the way, and each one of those needs to be fully specified. Remember, for all of our cohorts, we had to create concept sets, remembering each and every code that we used in our things. That is all fully specified. So now everybody in the world, no matter what their database is, they will know exactly how we defined our populations and how people could go to replicate that exact same study. You can see it's actually quite a lot of content that has to be shared in order for someone to understand all the details of this analysis. But the point of having this be an automated output of the process is that now they have complete transparency of exactly what's happening. So, Bonnie, you've got a protocol already produced by the code. Let's go back. Yay! So, the next thing that this code can do is it can create the cohorts. So we've now designed the cohorts. We know how to go find people with endometrial cancer and how to find people with lymph node metastases. But the code has to actually go find those patients and produce a data set that we can use for our analysis. And so by specifying create cohorts is true, that's going to go out to the data and generate the results. So of course we do have to do that. This code can also run the analysis. So this one little function knows how to go get the data, and it knows how to actually train the models that we've asked for. The code can then create a results document that's going to compile all of the output that we want and put it onto a screen, or put it into a document. This code can also package up the results so that individual organizations can share the files. So the reason we know we can do this study is because not only have I run the study, but I can actually create a folder of all of my results and I can give it to somebody else. That folder does not contain any patient-level data. It only contains the results of the model. What this means is if Bonnie is the study lead for this study, I can give her my files, and Kristin can give her her files, and we will have the file results from all of the different studies put together. This package can also create the validation package. So remember we discussed that when you create a model, you train a model, you might want to determine how well does that model work somewhere else in the world. And so by creating a validation package, we can allow other sites to test the model that we create. And so we could decide to train one model once and then share that with the rest of the world. And in fact, we might choose to do that after we look through our results. But the most fun part, I think, is these two statements. There's two things that this program does that I hope is going to make you very excited. The first one says create Shiny. Shiny is an interactive, is a package within the R programming language that allows you to write an interactive website to explore all of your results. So not only are we performing an analysis, but we are generating a website that we can post in the world that will allow people to explore all of the results that we've generated. So this one package is producing an interactive website. The second thing that it's going to do is it is going to create a journal document. This package is going to write our paper for us. Is anybody interested in seeing the website of the results? Yeah? Okay. So let's start by looking at the website of the results. Let's see, let me make this a little bit bigger so you guys can see it. Okay. Still a little bit hard to see, but bear with me. So what I am showing you here is an interactive website that we're going to play through with all of the results. This website did not exist 20 minutes ago. This was generated automatically based on Bonnie's question. And I'll prove it to you. We'll look through the results. So just to orient you to the screen, you're going to see on the left-hand side there's several tabs summarizing things that we're going to look at. We're currently on the Summary tab, but we're also going to be able to look at the model performance, and then we're going to get to look at the model itself. So we're on the Summary tab right now. Let me close this and give you a little more space. And forgive me, I'm going to shrink this down just so you can see it a little bit better. Up top here, there are 3 or 4 tabs. This tab says Results. This tab says Model Settings. This tab says Population Settings. And this tab says Covariate Settings. And in this table, we're seeing some of the analyses that we've run. There are filters here on the left-hand side that I can filter to particular results. And here, I filtered down specifically to Bonnie's research question. So just to orient you to this one that's, actually it doesn't really matter. I'll highlight this one here first. So to read across what this says, this is analysis 1. I ran this analysis on the CCAE database, which is a US claims database that I happen to have access to. Our target cohort was persons with endometrial cancer with their additional inclusion criteria. And our outcome was secondary malignant neoplasm of the lymph node. That's our lymph node metastases. The model we ran was a lasso logistic regression. And our time at risk was 14 days to 365 days. This is what you already knew. This is what you told me to do. But now I'm going to tell you how well the model worked. The next statistic over is the area under the ROC curve. This is the number that, remember, 0.5 is a random guess. 1 is a perfect model. Models that are used in practice, like the CHADS2, get you an AUC of like 0.65. Anything over 0.7 would probably be pretty good. Bonnie's model right now gets a 0.7899. The next statistic over here is the area under the precision recall curve. We get a value of 0.18. I'll talk about that in a little bit. Let me zoom out just one more time so we can see the full statistics here. But we can also see that, remember, we had to split the data into a training set and a test set. So this is telling us how much data did we have to test our model. And here, when we split our population into a 75% training set and a 25% test set, we were left with 5,500 patients who were endometrial cancer patients. And of those, 305 of them experienced the outcome of lymph node metastases in that first year. That gives us an incidence of 5.5%. What that says is in our test set, 5.5% of our endometrial cancer patients developed lymph node metastases. And so the prediction problem that we are solving is, can we find those 5% of people and discriminate them from the 95% of people who did not develop lymph node metastases? And what we're saying here is we were able to do that pretty well with an AUC of 0.78. Now the next row down is the second time at risk that Bonnie asked for. So the same target cohort of endometrial cancer, the same outcome of lymph node metastases, but now the time at risk is a 3-year horizon. And we can see that for that cohort, because we required all people to stay in the database the whole time, our data set was much smaller. We only had 2,700 patients in our test set, 350 of which experienced the outcome. That gives us an incidence of 12%. So the question is, how well can we discriminate the 12% of people who got the outcome from the 88% of people who didn't? And here, that model achieved an area under the ROC curve of 82%. So this is saying, based on the predictor variables that Bonnie selected, and in this database, we can do a pretty good job of predicting lymph node metastases in the next 3 years. So I'm going to go through the steps here. So the additional tabs that we have here, you can see the model settings, so you know exactly what model was run to perform this study. We can see the population settings, so you know exactly what choices we made when fitting this model. And we can see the covariate settings to know exactly what choices we made in our studies. So just as it's important to write a protocol that pre-specifies what you're going to do, it's very important for us to also communicate when we show the results exactly what we did do. And so that's why this information is always going to be shown next to all of our results. Okay, so let's dive into one of these models and think about what it actually means. I'll take, do you care about the 1-year result or the 3-year result for purposes of talking through it? The 1 year? Okay, so we're going to start with the 1-year results just to go through this. So I'm going to start by going through evaluating the performance of this model. And here we've provided an interactive dashboard where we can explore the consequences of deciding on different thresholds as to what will happen to our sensitivity, specificity, and positive predictive value. Specifically, what you're seeing here is this dashboard is showing us that if I set the threshold at this value, well, we know the incidence of the outcome is 5.5%, but based on this threshold, I can see the positive predictive value, the specificity, the sensitivity, and the negative predictive value. So, at this threshold of 15%, the way to think about this would be, we've given every patient a predicted probability. We could decide that we're going to call people high risk if their predicted probability was greater than 15%. So what would happen if we did that? Well, 15%, we know that that's 3 times higher than the overall incidence. So if you're 3 times higher, maybe you feel like you're really at higher risk. Well, what happens if we say you're high risk if your probability is 15% or more? Well, here's what happens in terms of our 2x2 table. We see that we would have predicted that 390 people would have been predicted as high risk. And of those 90 of them would in fact be the patients who develop the lymph node metastases. That means we would have 300 false positives, and we would have 200 false negatives. The majority of people, we would have predicted that they were not going to have the event, and they indeed would not have the event. So that gives us a positive predictive value of 23%, meaning if we classify these people as high risk, 1 in 4 of them are in fact going to get the outcome. That's pretty good if we think about the fact that the incidence overall is 5%, which means if we were to randomly guess, you'd have to get 20 people to find one that was going to have the event. But now I've only got to select 4 people to get the event. That's pretty freaking good. I don't know if that translates. So now if we can find 4 people, 1 in 4 of them are going to have the outcome. That's much, much better than 1 in 20. Now, how many people, though, meet that threshold? Well, we can see the specificity is about 95%, meaning we're only going to have about a 5% false positive. We're only going to have to select 5% of people who don't have the event to incorrectly. That's still a good number. I mean, that's still, we've got to find, we're going to have to work our way through 300 people in this cohort, so it's still a lot, but it's a relatively small fraction from the 10,000 that we're working with, or 6,000 we're working. What's particularly interesting to me, though, is by setting this threshold really high at 15%, we're going to find 30% of the lymph node metastases in the future, in the next year. So that means that by setting this threshold and only really selecting the top 5% of the people in the whole cohort, we're going to find 30% of the outcomes. So think about the alternative to this, is we have all people with endometrial cancer, and we could either be worried that they're all going to get lymph node metastases, or we could be worried that none of them are going to get lymph node metastases. But that's what we have to do if we don't have a prediction model. Now, if we set this threshold here, we can identify 30% of the events using less than 5% of the population. That's pretty amazing. And when we identify that threshold, 1 in 4 of those people will actually will experience the event in the future, which is much, much better than the 1 in 20 guess we would have to do without this model. Now, we could decide to change that threshold. We've just set it here arbitrarily at 15%. You might say, I want to be more stringent. Can we do better if we set it at a higher number? And in this website, we can actually just drag the threshold to whatever we want. So for example, maybe I set my threshold all the way up at 25%. We'll say we'll only identify people as high risk if their probability of having a lymph node metastasis is greater than 25%. So you can think about that 25%. That's 5 times higher than the average incidence rate overall. If we were to do that, you can see that our positive predictive value has now increased all the way to 28%. So that's much better. That's even better than the checking 1 in 4. Now we're almost up to only 1 in 3 have the event. You can see our specificity went up. So now we don't even have as many false positives. So that's good. But our sensitivity has gone down. Now instead of identifying 30% of the cases as high risk in our high risk group, now we've only identified 15%. Again, that represents a trade-off of specificity and sensitivity. So we could reduce it, perhaps. We could say, well, maybe I'm interested in, I don't know, pick a number here. since the average incidence is 5%, maybe I'll lower my threshold to 10%. If I lower my threshold to 10%, now we can see that my positive predictive value has gone down to 20%. But that 20% is still pretty good. It means 1 in 5 people are going to have the event. That's pretty good. You can see that now I have to accept the fact that there's 10% of the people I didn't want to get. That's my specificity. But now my sensitivity has gone all the way up to 40%. So now we're finding 4 out of the 10 lymph node metastases by setting our threshold to 10%. There's no right answer to what the right threshold is. It's just a matter of what decision that we would like to make and how we want to use the model. But the reality of it is, our alternative is, before Bonnie asked this question, we didn't have a prediction model. So we're trying to do better than not knowing which patients are at risk. And this is suggesting to us that now we might have a tool that could actually be much better. Now, you all can play with this threshold and see how the numbers change. But there's a way that we can summarize it. I'll go back to my 15% number just so you can see it kind of cleanly. The way that we can summarize that as a continuous value is by looking at a receiver operating characteristic plot. Because this plot is plotting sensitivity versus 1 minus specificity, or the false positive rate. So that line that's drawn down the screen, that's your threshold. That's if we set the value to 15%, what you would see. So that's how I know that we achieved a sensitivity of 30% for a false positive rate of about 5%. It's because that's where the black line intersects with this ROC. So when we say the AUC, the area under the curve, was 0.78, that's literally saying, if you think of this box as an area, we're saying 78% of the area is filled in blue. That's actually what that number is. We would like to have a prediction model where it was completely filled in. That area in white, that's the stuff we can't yet predict. But it's pretty exciting that we can predict 30% of our cases using less than 5% of the data. This plot is showing you how we can find the people who are at high risk, and I think that that has tremendous value. But you can also flip it over and look at the people who are probably at very low risk. So you can see up here, if I were to look at my risk threshold of, say, let's say 2%, at 2%, so remember the average incidence is 5%. So if I set a threshold at 2% and said, let's call everybody who has a probability less than 2%, let's call them low risk, because of course they have a risk that's less than half of the average risk. Well, if I set my threshold there, what I can see is that fewer than 5% of the cases that will happen fall into our low risk group, and yet 30% of our group, 30% of our patients in endometrial cancer would get classified as low risk. So I want you to think clinically about why this is important. Instead of treating all patients with endometrial cancer the same, we can now split the group of endometrial cancer into 3 groups. There's a small group that we can call high risk. So we can take 5% of the people and call them high risk. We can take 30% of the people and call them low risk. And then we've got the people in the middle where we don't really know. They're somewhere between high risk and low risk. But wouldn't we possibly be able to care for our patients differently if we knew there was a small group with really high risk and another big group with really low risk and then a group in between? We could think about treating our patients differently if we knew which group a patient fell into. This model, because it's performing so well, is actually providing us the ability to do that. We now have a high-risk group that we can think about what to do for that. And we've got a low-risk group, and we can think about what we would do differently for that group. So with this one model, because every patient is getting a predicted probability, we can use it both to find high risk and to find low risk at the same time. So this plot, this receiver operating characteristic plot, is something that can be quite a powerful clinical tool to think about how to set thresholds and how to use that information to define what populations you might be interested in. This plot to the right-hand side here is a precision recall plot. This is another way of thinking about how well the model is working. So precision is another word for positive predictive value. So that is that idea of amongst the patients that you identify as high risk, what proportion of them indeed have the outcome. And what you can see is that that value seems to range somewhere in the 20s, and then eventually it tails off, with recall being sensitivity. The more cases you want to find, the lower your precision gets, which is oftentimes the case. So if we've set our threshold here, you can see we've still set it at a point where it seems to be that probably 1 in 4 is about as good as we can do with this model in identifying people at high risk. Now, some people would say, I want a model better than 1 in 4. I want to be able to identify I want a perfect model that completely classifies it. But it's important to reinforce that our comparison is not having a model at all, or to think that if the background rate is 5%, then you would have to randomly guess and you would only be right 1 out of 20 people. So the fact that we can be right 1 in 4 instead of 1 in 20 is a pretty big step forward. Another statistic that is used in predictive modeling is the F1 score. This is a score that basically is trying to be just trying to bring together the sensitivity and the specificity into one metric, where the higher the score, the more combined accuracy you're observing. And you can look at that score as a relation to the prediction threshold, to basically decide that if this was the threshold we liked, 15%, you'd like to make sure that it is fairly kind of towards the top of what that F1 measure is showing. And you can see here that the F1 measure seems to be pretty constant around about 0.25 in this range. And so that we're probably in a good, we probably could think that this is a reasonable threshold to consider setting. I'll actually show this plot because it'll probably make more sense. So remember that I showed you that when we are producing predictions, we are producing predictions for a distribution of, we produce a distribution of predictions for the people who do have the outcome and a distribution of predictions for the people who don't have an outcome. And you can tell how well a model discriminates by how much overlap there is in those groups. These plots are actually showing you exactly what happened in our model. The blue represents the distribution of prediction values for the people who do not go on to have the outcome. And the red represents the people who do go on to have the outcome. And so what you can see is happening in this case is at different prediction values, you can see a large amount of the people without the outcome have really low predicted probabilities. The people who do have the outcome, they have a more wide spread of possible values. And so this threshold of 15%, you can see that if we look to the right of that threshold, most of the people are in the red group. And if you look to the left of the threshold, most of the people are in the blue group. that's how we know that the model's actually doing a good job of discriminating. And if we change that threshold, that's what's changing the number of true positives, which would be the red to the right. The false positives would be the blues to the right. The true positives are the blues to the left, and the false negatives are the reds to the left. And so by moving that threshold, you can see exactly how this plays out. The preference score is the exact same information. It's just scaled to tell you what is your probability if the outcome was a coin flip. So we know that it's not a coin flip to get a lymph node metastasis. It's only a 5% event. But if you wanted to know what would it be if this is like a 50-50 chance of having an outcome, then that's how those two distributions would separate. And that can be helpful just to make comparisons between models. And it helps you to see very clearly that we are doing a pretty good job of discriminating the red group from the blue group. Before I flip over, any questions about discrimination? What? Awesome. What's your AUC? Okay, so same ballpark. Should have had 8. Okay, we're good. All right, so no questions about discrimination. Remember, we talked about that there's 2 things you want to look at in a model. You want to look at discrimination, and you want to look at calibration. So let's see whether our model gives patients the right predictions. So this calibration plot to the left, it's showing you the predicted probability for our patients. And on the y-axis, it's showing you the actual rate of events that occurred. And so remember, as I showed you in the slides, the dashed diagonal line, that's what we would hope, is that the predicted probability is the same as the observed frequency. These little black dots represent what happened in our model. Each dot has a little confidence interval. The simple way to think about it is you hope to see that the confidence intervals cover the diagonal line. If they do, then that means the predicted probability is pretty close to the observed frequency, which means you can trust the model. We're pretty darn close all the way. This one looks like it just missed a little bit, but in each of these groups, all the way along the way, it looks like we've got a very well calibrated model, which is exciting. It tells us that we're not producing numbers that are way off from what's actually happening. Another calibration plot that we can look at is to stratify the population by age and by gender. In this particular case, we only have one gender, so it's not as interesting. We've got females, but we have age groups. And what you're seeing here is the observed risk within these age groups is represented in this light red line. And the blue line is our prediction. And if you're having a little bit of a hard time telling them apart, it's because our observed probabilities are right on top of our expected probabilities. That is to say, our model is doing a good job of modeling the risk, which looks like it's slightly going up by age. And you can see that our model seems to also get that kind of right, except for the very last age group. Something seems to be a little bit funky there. It's probably a sample size issue. So, from a calibration perspective, I'm thinking that we're doing pretty good. To go back to the analogy that I tried to provide this morning, we're flipping coins to figure out who's going to have outcomes and who's not. What we've just shown you is that we've got a black box model that is doing a better job of guessing our coin flips than randomly guessing. In fact, it's doing a pretty good job. It's got an AUC of 0.78, which is pretty darn good. So we could stop here. We have a model, and we know that it works pretty well, so we could start to think about how we should apply this model. But it's important to know what is in the model, not because we are going to try to explain causal factors, but simply because when we look at a model, we want to understand what variables are required to apply it to another circumstance. So we can look at exactly what variables went into our black box and begin to try to understand whether it makes sense. So this plot here is a very important plot, and it's very colorful too. This is showing you a dot for every baseline predictor. So every covariate we put in, demographics, conditions, drugs, procedures, there's a dot for all of them that was selected in the model. And the plot is representing the prevalence of that baseline characteristic in the group who did not have the outcome. And it's plotting it against the prevalence of that baseline characteristic in the people who do have the outcome. So the 45-degree line represented by the diagonal, that would be a variable that by itself is not different in the two groups of people who had the outcome or who didn't. So you could think on a univariate basis, any dot that is far away from the diagonal line, that's telling you that that variable is different between the people who go on to have the outcome versus those who don't. The number of dots on this plot, that is the number of variables we had to select to build our model. And so you can see in this case, we actually picked a pretty large number of variables to be able to figure out which patients have lymph node metastases. So what are those variables? Well, in the website, you can actually just hover over any of them and see what they are. So what is this one? So this one, for example, it is the variable bleeding. It's saying women who at the time of their endometrial cancer or any time in the past, if they had an occurrence of bleeding, it's saying that 50% of the women who went on to get a lymph node metastases, 50% of them had bleeding in their past medical history, but only 29% of the women who do not go on to get lymph node metastases had bleeding in their record. So this is important to reinforce. This does not tell us that bleeding causes lymph node metastases. This is only an association. It is not causation, and we can't interpret it in anything other than the model that is doing a good job of predicting lymph node metastases happened to need to use this variable bleeding, and bleeding by itself seems to differentiate people who got the lymph node metastases from people who did not get the lymph node metastases. And so therefore that one variable was selected by the model. Let's find another one here. Actually, this is interesting. You can see here that whereas that first variable was bleeding all time in their medical history, this next one that I'm selecting is bleeding in the 30 days before the index. Remember that Bonnie selected different covariate windows. We said all time prior and in the immediate 30 days. And what's interesting is the model found information in both of those variables. And you can see that if we just use the 30-day window, it turns out that about 40% of those that go on to have a lymph node metastases had bleeding in their 30-day window, whereas only 14% of the women who do not go on to have lymph node metastases had bleeding in this 30 days. Again, this does not tell us that bleeding causes lymph node metastases. It's simply telling us that there is an association. But it may be interesting to think about that, particularly because the primary symptom of endometrial cancer is bleeding. And so potentially the severity of the bleeding can also be reflective of the stage of disease, which could be associated with the likelihood of getting lymph node metastases. Okay. So what I just described is a plausible hypothesis of why this might be happening. This data does not tell us why this is happening. If we wanted to test the hypothesis that bleeding causes lymph node metastases, we would now need to design a new estimation study. But what this model can do is find us associations that can lead us down new trains of thought of what to explore. Importantly here, I don't know anything about endometrial cancer, so I don't even know what I would expect to see from a model like this. It's only after the model says that bleeding is an associated factor that I would then go in to say, why is that happening? And sure enough, when you look in the literature, you see a lot about the severity of bleeding is a quote-unquote risk factor for stage of disease. I didn't tell the data to give me that answer. The data told me to explore that association. So you can see that there are many dozens of different variables that have been selected by the model. Each one of them could warrant its own exploration. All the variables that were considered for this model are provided in this very large table. You can see that for this one model that we've done for Bonnie, we considered 38,000 different baseline characteristics. We looked at 38,000 different things to try to create the black box model to predict as best we could. And you can see from that picture up top, we only ended up needing a few dozen to be able to create this model, but we selected the few dozen from 38,000 options. And you can go look at all of those baseline covariates in this tool. Here you can see, for example, maybe I'll just do this. Let's search for age just to be age group. For example, maybe I'll pick up. There you go. For example, you can see here is our age groups. We thought to put age in this model, or we thought to consider age as a possible variable. And you can see for every age group what percentage of people who had the outcome were in that age group and what percentage of people who were did not have the outcome were in that age group. This other variable here, though, this is what is that beta coefficient to the model. So we've run a logistic regression. So what is the beta coefficient to tell you the magnitude of the effect? If it's 0, it means the model didn't select that variable. So this turns out that in this particular case, the model did not select age as a predictor. We didn't need to have age in order to predict our variable, our model. That does not mean that age is not important. It simply means that variable was not selected by the model. We can see if I go back age in years. Why was it not selected? And this hopefully will illustrate the point. The age groups were not selected because the continuous value, age in years, was selected. It got a beta coefficient of 0.92, and it's because the people who went on to have the outcome, their average age was 50 years old, whereas the people who did not go on to have the outcome, their average age was 48. So there was a slight difference in age, and therefore the one continuous variable, age, was selected from the model, but the individual subgroups of age were not selected in the model. The reason I'm taking the time to explain this is because this is exactly the reason why you cannot say that a variable matters or doesn't just on its coefficient, because we have multiple variables that are correlated with each other that can explain that are the reason why an algorithm chooses one versus the other. All right. So, with all of that as a caution, I'm going to at least highlight. So, again, we should not be using the size of the coefficient to tell us what are causal factors, but you might be interested in what factors did get selected by the model. And so just to show them on the screen, I'm highlighting, sorting on the beta coefficient. And so we can see the types of variables that we see. So secondary malignant neoplastic disease has been selected. Now, we thought we excluded those, but one of the things we recognized in our cohort definition was we only excluded cancers that were before day 0, which means we allowed for the possibility of having a secondary code on day 0. The fortunate thing that we can see here is that represents less than 5% of the population. So even though it's been selected and we may want to revise our cohort based off of that, it's not a major reflection of what's going on. The next one down here, though, biopsy of cervix. So the biopsy of the cervix, of course, that's the procedure that one would perform to then go and inspect the lymph nodes to see whether or not you observe anything. So here we can see biopsy of cervix anytime prior. 17% of the people who go on to have a lymph node metastases have had a prior biopsy of their cervix, whereas only 5% of those that did not have a prior biopsy. This is not saying that biopsies cause lymph node metastases. It's simply saying that whether a person has previously had a biopsy is some sort of an indicator for whether or not they will have a lymph node in the future. Here we see bleeding. We see abnormal menstrual cycle. The next one is actually quite interesting. Whether or not in the last 30 days you had a measurement for your immunohistochemistry or immunocytochemistry. So someone trying to measure what is going on in your panel, it turns out that 27% of people who go on to have a lymph node metastases had that measurement conducted in their prior 30 days, whereas only 10% of the people who do not go on had that measurement. We can see having a diagnosis of intra-abdominal and pelvic swelling, mass, or lump. We can see non-inflammatory disorders of the female genital organs, postcoital bleeding, a measurement of cytopathology in the cervical or vaginal system. You can see whether or not someone had an echocardiogram, whether or not they've had an acute urinary disorder of some sort, whether they've had a procedure of a coloscopy of the cervix, whether they've had a transvaginal ultrasound, whether they've had a measurement of prothrombin time, whether or not they've had a positive pap smear, whether or not they've actually been measured for whether DNA or RNA for, I'm not going to pronounce that. So these are all of the variables that the model is using to be able to predict who's going to go on to have lymph node metastases. There are also variables that are on the, go to the other side. There are also variables that have negative predictors, meaning their beta coefficient is negative. So just to provide an example, let's see, I'll pick one here at random. Chest pain. Women who have an observation of chest pain, 20% of the women who go on to have the outcome have had that, whereas 26% of the people who do not go on to have the outcome have had chest pain. Clearly, having chest pain does not cause or reduce the risk of lymph node metastases, but something about women who have chest pain is associated with this future outcome. So bringing this all together, if we have a single model that uses all of these predictor variables, then we have the ability to predict the outcome of lymph node metastases with an AUC of 0.78. This is still a very, very difficult model to use in clinical practice. This is quite harder to do than that CHADS 2 score, where you could count it on one hand, whether you had CHF, hypertension, age, diabetes, and stroke. This is not something that you would do as a doctor by hand. Instead, this is a model that you would require be installed inside of your electronic health record system, such that when you typed in someone's medical history, the screen could simply report back a person's individual predicted probability. Not all hospitals have electronic health record systems that are currently prepared to use such a technology. But the vision and the implementation that we have makes it possible to do such a thing. And so if you are working in a hospital that does not have a system that allows for prediction models to be available to the clinicians, I would encourage you to speak up and think about how to encourage your hospital system to make this become possible. Now, this is one prediction of one disease and one outcome. You probably wouldn't change your entire electronic health record system in your hospital just to help women with endometrial cancer predict their lymph node metastases. But imagine if you had a model like this for every disease and for every outcome, and that every time you were treating a patient, the likelihood of their future experience could be made available to you. That is now a reality that we could live in based on the technology that's been developed in OHDSI. But it's going to require health systems to adopt the OMOP Common Data Model and use these open source tools to embed that into their clinical systems. So the paper that we're going to write together is going to describe this model and hopefully encourage health systems to think about how they could adopt this. But being very realistic about it, most systems will probably not immediately implement this model into their systems. But what we can at least do is communicate to researchers around the world that it is indeed possible to predict lymph node metastases in patients with endometrial cancer. And that we've done this analysis in one database thus far, and this already represents the largest analysis of endometrial cancer that's ever been done. We've just did it in an afternoon. This model that we've produced is quite complicated with lots of variables, but what could be done by using this information is it could help us start to think about what if we too wanted to create a simple model by just picking 5 or 6 variables ourselves. If we did select bleeding, and let's pick a few here, we could select that bleeding risk, excuse me, this measurement of immunohistochemistry, the biopsy of a cervix, this non-inflammatory disorder. If we picked 5 or 6 variables, we could then train a new model and ask the question, how well does our model work if we only use these 5 or 6 variables? And what we would be able to do is to compare the performance of the model. This represents the optimal model if we use all the data. But we could also look at this if we only used the 5 or 6 variables. I can guarantee, we know mathematically guaranteed, that 5 or 6 variables are going to do worse than all of the variables. But what we don't know is how much worse it's going to do. If the 5 or 6 variables got pretty close to this, we could make an argument that having a simpler model is worth the decrease in performance, because a simpler model is something that clinicians could count on their fingers and make use of easily enough. If, however, we saw that 5 or 6 variables only gets us an area under the curve of 0.6, whereas our full model gets us an AUC of 0.8, well, then you have to ask yourself, is making the model simple to understand hurting our ability to improve the lives of patients? And my personal opinion is that if we were in that situation, I'd rather us invest in making our computers better than do worse things for patients just because it's easier to think about. All right. Let me stop there and see if there's any questions about the model. So we've now talked about performance, and we've talked about the model variables and what's contained in it. Any questions about that? Okay. All right. So I'm going to go back, and I'm going to highlight that the problem that Bonnie specified was a very, very well specified problem. We were interested in people with endometrial cancer and then looking forward for their lymph node metastases. One thing that I was uncertain about was how much we are sure that those people that have the code of endometrial cancer truly have endometrial cancer. Because just because they have the code doesn't mean it's necessarily correct. So I thought, why don't I create a cohort of patients? Oops. Yep, there we go. Why don't I create a cohort of patients? I'll just select it that way so you can see it. Who are persons who've had a hysterectomy for their endometrial cancer. The idea behind that is if a woman has endometrial cancer, the most common treatment for the endometrial cancer would be a hysterectomy where they remove the uterus. And so if a person has a code for endometrial cancer and they get a hysterectomy, pretty sure they probably thought that they had endometrial cancer and they've been treated for it, whether or not it was true or not. When I apply that model, we can see for the same outcome of secondary malignant neoplasm of the lymph node, we can see the performance of this model went down a little bit. The AUC for 1 year is now 0.70, and for the 3-year window, it's 0.73. Now, 0.7 is still quite good, so we should still be quite happy with that, but it went down, and at least part of the reason it might have gone down is because we now have a cleaner target population that got rid of those secondary malignant neoplasms that we probably didn't want in the past, and we've now anchored on the date of the procedure rather than the date of the initial diagnosis. So it changes the clinical question that we would be predicting. But still, if I were to look at one of those models, I'll look at the 1-year model there again. So now we can see that we have a different ROC plot. It looks a little bit less blue than it was before. That's how you know it's less performant. But even still, I can see that I can find 20% of the lymph node metastases using less than 5% of the data. That's still quite encouraging. If I look at my calibration plot, I have much less data now, but I can still see that I'm not observing anything to make me worried about this model. But here, my prediction threshold's much different, because now the incidence of secondary lymph node metastases in people who actually get all the way to the point of having a hysterectomy was only actually 3% in this population, 2.7%, whereas before it was 5%. So changing our target population has actually changed the baseline risk of this group. And here my threshold that I might be setting is now 6% instead of 15%. You can see that the positive predictive value has gone down. My sensitivity is at 20%. The reason I'm sharing this is to reinforce that the context of the prediction problem is very important. You need to be able to define which people are you trying to produce a prediction for. And in this case, there's a difference between all the women initially diagnosed with endometrial cancer and the women who have endometrial cancer who get a hysterectomy. Even though some of those women are the same, their risk of the outcome is different, and our ability to predict the outcome is different. We also took the liberty of choosing a different outcome beyond the one that Bonnie had suggested. Secondary malignant neoplasm of the lymph node is a specific, so lymph node metastases is a specific outcome that we may be paying attention to for endometrial cancer. But as we discovered in our review of the literature, there's also a challenge, which is you can observe lymph node metastases at the very time that you are trying to treat the endometrial cancer. So it is not necessarily just an outcome that you observe in the future. It can also be something that's observed at the same time. In particular, you may remove the lymph nodes in order to stage the endometrial cancer, which actually means the lymph nodes had metastases before the endometrial cancer, not after. So just for the interest of fun. We decided to look at the outcome of secondary cancer. So imagine a different clinical situation. You're a woman who has been diagnosed with endometrial cancer. You've had a hysterectomy to remove your uterus to try to remove the cancer. I think a logical question that many women would have in their mind is, now that I had endometrial cancer and I've been treated with a hysterectomy, what's the chance that I'm going to get another cancer? I bet you just about every woman who's been treated for endometrial cancer has probably asked that question to their clinicians. And so we thought, can we predict which women are going to get a secondary cancer after the endometrial cancer? And it turns out that if we're trying to predict the 3-year risk of getting a secondary cancer, we can do that with an AUC of 0.807. A simple thing that we can observe is that in this particular database, 20% of women who had endometrial cancer, 19%, go on to have some secondary cancer in 3 years. We would need to verify whether or not that is actually true. However, when I was looking online just to try to understand this during the lunch break, one of the things that I found interesting, I don't know if I still have it open. Let me see if I do. I still have it open. I don't have it open anymore. No, I don't have it open anymore. The American Cancer Society has a page for patients, and it said something to the effect of, if you're a woman who's been treated with endometrial cancer, you might be worried about whether or not you get cancer again. It says, you are indeed at risk of cancer. Watch out for it. It provides no numbers, no probabilities, no guidance other than to continue to monitor yourself for cancer. My opinion is that if we can learn a likelihood of getting a secondary cancer, and we can discriminate the women who are going to get a secondary cancer from the women who are not going to have a secondary cancer, that would be very valuable to provide to patients, just to reassure them about what their risks are. And it could also be very valuable for those of you who are becoming clinicians to actually educate your patients and think about how you might treat them accordingly. So this model looks much better with an AUC of 0.8. You can see here, let me highlight over it. I mean, shoot, look at that. I can find over a third of the secondary cancers that are going to happen in the next 3 years. I can find over a third of them using less than 5% of the data, 5% of the population. So to go here and look at what that means, so let's set the threshold here at 50%. So this model, the incidence overall is 20%, but we could set a threshold for people at 50%. 50%, it's a coin flip now. So we could say, if your probability is higher than a coin flip, then we're going to call you high risk. And it turns out that less than 3% of the population, or about 3% of the population, is more than a 50% risk. But if you're in that 3% of the population, we have a positive predictive value of 70%. That's very high. It means that if I have 4 people, if I pick 4 people, 3 out of the 4 are going to get the outcome. Now we're talking about something very high risk. And even though I'm only using 3% of the population, I'm going to find 30% of the events. That's pretty remarkable if we think about that. Using 3% of the people that are at risk, we can find 30% of the cases that are going to happen in the future. So again, the power of this prediction model is that we're able to actually figure out how often does something happen, whether or not we can predict it, and what kind of thresholds that we could set. And then we can additionally dive in to understand how many variables does it take for us to be able to predict, in this case, secondary cancer amongst women with hysterectomy. And we can see, interestingly, that measurement for immunohistochemistry pops up again in this model. What it's suggesting to me, anyway, is that clinicians probably know which patients are at high risk or not, because they're ordering measurements and tests to be worried about them. But the fact that a measurement's taking place means a clinician has a suspicion, and that suspicion is grounded in the fact that that might indicate higher risk. Whereas if women have different, less severe cancers, such as carcinoma in situ of the uterine, there, knowing that you are starting with a less severe cancer, that is a negatively associated with future secondary cancers. Again, we can see many different predictors here that are quite helpful in trying to discriminate the women who are going to go on to have a secondary cancer versus those that are not. So let me just stop there and see if there's any questions. All right, so one more little thing. So we just looked at the Create Shiny app. That's what we were just playing with on that interactive website. But the software is also going to create a journal document. I don't know if I've got it open. There, got it open. So congratulations, Bonnie. You've just written your first paper. Your paper is titled The Development and Validation of a Multivariate Model to Predict Secondary Malignant Neoplasms of the Lymph Node in a Target Population of Persons with Endometrial Cancer during the 14 days to 365 days using observational data. Maybe you want a catchier title than that, but it's a start. Your paper has an abstract that describes your objective, the study design, the settings, the participants that you know that you've used 22,000 patients to find the 1,200 who've had the outcome during the time at risk. There's a few things we're going to ask you to fill in from that Shiny app. You can see that you've run a lasso logistic regression, and your results are that you got an AUC of 0.79, and that you've got some calibration plots that indicate that you're well calibrated. There's your abstract. You've got to write a background to your paper. We've provided a little bit of text about thinking about what your prediction problem is. You can do a little bit of a literature review to provide why you think this is an important question. But the manuscript is providing you all of the pieces that are either required in the tripod statement for recommended best practices, and it's either in here or it's available on the website for you to just paste in however you want. So here you can see these are the variables that were selected as the predictors that you might want to use, a description of the statistical methods we've applied, and here are your results. You have an attrition table that's describing the population we started with, the rules we followed to get down to our final population of 22,000 patients. That's your figure 1. Your figure 2 is showing you all of the possible covariates that you could have selected amongst, with those green dots being the variables that were actually selected in the model. The model specification is going to actually be in the appendix, but that's going to be your listing of the hundreds of variables that were selected. Actually, here it is. Out of the 38,000 variables that it was available, you identified 227. And so the listing of the 227 variables will have to be in the supplement. Your paper then describes that you were able to train, and your internal validation results are available here, including the figure that you'll have in your paper showing the area under the ROC curve in both the test and the training set, and your calibration plot that's showing that you're well calibrated. So these are all the recommended outputs that you should include in your paper. You are going to need to help us a little bit with interpreting this from a clinical perspective to think about, because I don't know and the software can't know why this matters. But we've provided you the section and the recommendation to tell you exactly what you need to write to interpret how are you going to use this now that we have a model. There are limitations that you should generally think about for all models as we describe that. And then we get you started with your conclusion. And as with any paper, you're going to have appendices that provide you all of the details. And so in this particular case, this appendix, this is your model. These are the variables that the model selected, and there's their covariate value. So now anybody could take this information and apply the model in their own circumstance. But importantly, they probably wouldn't type this information from a document. They're going to be able to take the code that we've generated and saved as a package, which is now publicly available for anybody to grab and reuse in their own local environment. So there's your model, and there's your paper. This is the point where you're supposed to be standing and clapping for Bonnie for writing her first paper. So, we just designed a study. We executed a study in our database. And I executed a study in my database, and we've generated results. But the power of the OHDSI community is that we as a class designed the study. I was able to take that study and run in my data. But at the same time that I was running in my data, Kristin was running it in her data. So now Kristin is going to show you what happens when we try to learn about endometrial cancer in the data that she has access to. I'm just going to leave my laptop here, if that's all right. Just want to basically just go through the exact same thing, because I did it twice.
Give me 1 second while I view the Shiny app again. Okay, a few of us. So maybe the magnitude or the intensity of how awesome this is a little bit lost, but it's actually really hard to run a study. I'd be lying if that wasn't true. Well, this is rendering very weird.
If you open it in browser, it's a little bit prettier.
Sometimes it gets angry when I do this. Let's see if it works. So let's see if this comes up. So this is going to look the same as Patrick's. I'm going to pull this out, see if this works. I want to try to make this tinier. See if I can zoom out. Yeah. So this looks like Patrick's, but let me tell you a secret. My technical environment is actually very different than Patrick's technical environment. And the cool part about the OHDSI analytics tools and the methods library is it doesn't matter. It doesn't matter how my data is stored in its database layer. It doesn't matter if I have a cloud where I'm computing or if I'm computing locally. We all get to the same place. So that, to me, is pretty darn awesome. Now let's see if I can scroll. I might have to do one more down. I'm going to quiz you guys because I think we can interpret this together. I'm trying to scroll. Come on. I think I have to go like this. Oh, man. I can't scroll past the TAR. My desktop is confined to a very weird resolution. Let me see if I can change the display size. This is like a square. Multiple monitors. Yes. Landscape. One, two, no. Detect. Is that, let's see, this is better. Okay. Let's see if this helps. All right, this should be, oh, it's not better. Multiple monitors. I don't know why this resolution is so. I'm trying. No. I'm trying to change the resolution because it's. Choose a second, but it doesn't. So I'll show you when you can see it.
You can choose extend.
Yeah, but it's not actually extending.
This one and click apply.
I still think the size is not going to be right, but we'll see. Because it's forcing a weird. See, the screen is cut off. If we drag this over, maybe this will work. I still think we're going to have the same problem.
So do you change the resolution of the second screen?
We might. I don't want this. I want the other thing.
Click the.
Let's see. Because this is confined. This looks more normal. Where is it? Try again.
Can we just go back to the resolution settings?
Well, it's going to be relative to this. Let's see how this looks. We will open in browser. Because if it's constrained, we'll need to know in a second what is the constraint.
Actually, we can set the second one separately from your main screen.
Come on. Let's see.
Using my instrument.
I am. Am I shiny is pulling from? Let's see. So yeah, this is forcing the same small size. We'll see when this renders. Hopefully it'll work. I'm not getting much on the scroll. Yeah, I'm getting the same as before.
Okay, can you try? I cannot try.
Now I don't have. I don't think that's going to change it. I think it's actually the.
Keep changing.
No, because if my IQVIA thing is cut off, then I know for sure this is going to be cut off. We need it to be pretty small. try. That's better, yeah, because it needs to be really wide, because this thing is, I guess, very, very wide. Let's drag that over. All right. So now we can see our results. Like, now we have to make it bigger. I can do that.
I can make it a little bit.
No, actually, well, it's hard. We're not even able to really see these numbers. They're kind of hard.
Maybe make this a little bit smaller.
Let's do, can I scroll? Why doesn't it let me scroll at all? Even in a browser.
You're seeing enough right now.
Yeah.
You've done everything you need to see now.
Still pretty small, so good luck if you are like me and nearsighted and back there. Okay.
You make it bigger.
If I make it bigger, I'm going to have the same exact problem as if I hadn't adjusted my monitors. It's not intelligent enough to know that when we make it bigger, we're going to lose the AUCs. It's just not. So even if I scroll, because I have no scroll for some reason. I don't know why. Kind of need, this is probably the best we're going to get. Pretty terrible. All right, well, I'm going to keep you on your toes and quiz you guys if you can actually read this, because I can barely read it. So, who remembers how Patrick's data performed? Does anyone remember what his AUC is, now that I've distracted you heavily with my AUC and my technical problems? Does anyone remember what the initial model was? 70, yeah. So, I'll tell you a little bit about my data, and then I'll tell you about I'll have you guys help me interpret this. My data is like Patrick's data set. It also is from a health insurance provider, or health insurance claims in the United States. It is commercial insurance. So I am looking at people who have access to care. I don't really have anything demographically different. It's pretty heterogeneous of the United States at whole. And Patrick's data and my data, a lot of people would say, if you didn't know them better, they're very similar. So when we look at our first analysis and we see, this is hard for you guys to see, it says I have an AUC of 0.81 for my regression, and my T in this particular line is our endometrial cancer cohort that you defined, and our O is the secondary malignant neoplasm of the lymph nodes. So just in your lymphatic system, did you develop a secondary malignancy there? So when we look at our performance, it's pretty similar, right? In fact, a teeny bit better. Maybe my data is a little bit better than Patrick's, maybe. But what's really interesting is that there is not a heck of a lot I see here that it's different in terms of the frequency. And I don't actually remember what your count was for your O's, but I think it was in the magnitude of.
More data there, looks like.
And this looks like
Like
it.
8,000 I had.
Sorry, it's getting. This is so weird. It looks like it timed out, but I don't see the little error message. Give me 1 second. Yeah, it does. Let me run it again. And this one has, oh man. No, it's actually because it's in the cloud, so I have to, I think, close it and reopen it. It doesn't, it's the fun of it. So how did I get to this point? Patrick shared a file with me. I connected to my own data. I ran it, and now I'm trying to interrogate it the same way he did. And the cool thing about the code is I didn't have to do anything special. All I did was look up, how did I connect to my database? I logged in, I ran it. And the interesting thing is I'm seeing similar performance to Patrick's data. I might not have even talked to Patrick yet, so I might be like, wow, this model, this is great. But what I have to figure out is, did I design this correctly? And we were talking about this, right? What were some challenges we identified in that first analysis? Does anyone remember? Was there anything about the covariates that we looked at that was maybe could have been questionable? Does anybody remember what that was? Yeah, time zero, right? I don't know this yet because Patrick and I haven't collaborated, so I'm looking at this blind. Oh, good, we're back. So I don't know this yet. I haven't gotten to that same finding, but does anyone remember how I would get to the same screen? Where would I go to interrogate the model? Yeah. We'll see how fast this renders. And I might be very naive to the actual clinical piece of it. I might have just received the package as a collaborator, and I actually don't know what I'm looking at. I just know that I was told some clinical expert validated this T and this O, and we feel good about the model. Can you run it on your data? And maybe it'll render. This is the fun of a live demo. I can't pre-populate it. So what do I need to do to feel good as a collaborator? Well, I'm going to do the same. I'm going to do the same test of my data. I'm going to look when it comes up. Really? It doesn't want to. I'm going to try to look at the model and figure out if there's anything very weird here. And let's go back to the summary for a second. We'll see if I can talk through it. And maybe this is where I stop in my network study. Maybe I don't even know how to open my Shiny app. Oh, man, it really doesn't want to render. Well, no, because it's on my environment. And so the challenge here is I am connected. I have served it up. I can't load. Well, actually, yeah, I could log into to RStudio from your computer, and it should be in the active environment. Yeah, because this is angry. Looks so easy when Patrick does it, doesn't it? But you know what? It's worth saying, when you run a network study, it looks really easy, right? I take the code, I run it. Yeah, we can try to do both. I take the code, I run it, and I'll trade 3 computers. We have so many here. Let me try to log into. But one of the hardest parts of this particular process is, can I replicate the same thing that somebody else gave me? So we can just leave that here. Let's see. Let's go to our PLT. I'm going to open my project. Yeah. So I work in the cloud, so I'm really lucky. Every laptop is my laptop. Maybe you're lucky like me. So I can just open up my environment again. I can try to look at my results. And Jing and I work together, so I know we can get on the same network. But you may have lots of collaborators you work with who do have their analytics in a little spot that only they can see, and they might have challenges accessing their data, or they might have challenges accessing the results they generate. Oh, man. Don't tell me it's in the local environment. Shouldn't be. No. Oh, you know what it is? You need, these shouldn't have to be, they should not have to be rerun. Hold on, function view Shiny. Yeah, that doesn't make sense. Come on. It's very weird. So that's very weird. So it means that what I have in my view, the session is not the same, even though, me go back. No, I don't want this session. Actually, I think I want this session. This is, let's see. Yeah, there, I have my database connections in here, so, but it's empty. Hold on. Let's see if this one's right. Yes, this is what I want. We'll let it do its thing for a minute. I think this is just pack rat, so we can stop that. Let's try this again. All right, this is a lot of sausage making. Yes, finally. All right, pretend that never happened. You're a new analyst working on the job, and you're looking at your models. Yeah, there it is again. It's amazing, right? No matter how we get there, it's still there. So let's go back to our tabs. We could see if we can get its surrender now. We can start to scrutinize it the same way Patrick was scrutinizing our model. Or not, you know, we can end up in the same spot we were before. Yeah. Let's see if I go to, no, it's just angry. Here, well, this is better. Does anyone remember what happens when I get to the screen? I'm gonna test you guys, because I'll tell you the truth. I was running my analysis and only sort of listening to Patrick, but I bet you were listening better than I was. What would be the input here? Why would I adjust the threshold? In fact, Jing, what does the threshold say for the value that I've selected here? So I have a spot picked and it's giving me this number. What does that mean?
It's kind of this threshold where you kind of, above it would be like positive, below it would be the negative.
This is pretty high, right? I probably need to lower it a little bit, or we could go higher. Could adjust it.
It's in the rated, that's the same as Patrick.
Yep. Exactly. And if I was being really, really thorough, I was looking in the literature around incidence rates for secondary primary malignancies following endometrial cancer. But what I found is that the rates are variable depending on who you are. In a Swedish population, it was up to 54%, so maybe there's something genetic. None of us are Swedish from what I can tell, so that statistic is probably only a 1 point estimate. So we see a similar incidence rate. We see a bit of information around our ground truth and ground negative, the positive and negative. But let's see. Maybe our rock plots are starting to look similar too. Yeah, look at that. We, without even having to be that sophisticated, have had a colleague help us generate our performance plots, our discrimination plots. So we have the ability to do the same interrogation. And what I think is really interesting about this particular output is that this is a lot of math. This is a ton of stuff that your package had to generate while it was running. And so it took me approximately 2 hours to go from creating the cohorts in my data, so that first step that Patrick walked you through, all the way through to generating the Shiny app. 2 hours, that's it. That's pretty amazing, right? But what's more interesting is we're starting to interpret our information here. And do we see anything that's maybe troubling about our prediction threshold? Anything about the way we have our outcome to no outcome? Do we feel comfortable with our threshold we've set? Have we set it too high, too low? Have we forgotten altogether what we're looking at? Possibly. Well, I have a secret for you. If you have forgotten where you are, you have a cheat sheet. It's called the Book of OHDSI. And you have a colleague who's already created a place to interpret your charts should you have forgotten what each of these things mean. And in the Book of OHDSI, you're very lucky, there's an entire section on the performance plots. So if you go to the patient level prediction chapter, and you click on, well, I guess both of them are, there are actually we're looking at a multi-model. There's actually an entire textbook to tell you how to read your Shiny app if you forgot the time that you spent with Patrick. And what's most interesting about it is that you can access this from anywhere, and soon there may even be a hard copy. But what I really like about it is that if I'm struggling to interpret a specific plot, maybe I'm getting ready for my journal article and somebody says, the reviewers are going to be really strict about this because we know that the existing literature, this is a flaw of a lot of observational studies. So we can actually look back and have some help from our colleagues on information about how to predict the average risk as a probability, how to interpret these plots. And obviously, our charts are not supposed to look identical. The fact they do is actually kind of coincidence. I could set when I run my model, it might look totally different. If I've not designed it well, I might have some legitimate design issues. But what we want to do is spend the time to be thoughtful as we're assembling our results and really think critically about each data source that contributes to our network study. So back to our plot, if we remember that these are ways to interrogate this specific model, we also can obviously toggle between models. And I'm really hoping if I click on model, yes, finally, the plot I really wanted to see, which was, what are all the things, these binary variables that we have created, how do they show up in my particular data? Because remember, Patrick was selecting things like bleeding. We saw different time periods of bleed that were interesting. And so in this one view, I can start to do a similar exercise. But what I can't see, it's a little bit, let's see if I make it upscale. Oh, makes it, that doesn't help with the box is getting cut off. Can start to scroll around. Does anyone remember if they saw transvaginal ultrasounds in Patrick's data? Does anyone remember if that was something that he observed when he hovered over his data? But we do remember bleeding, right? We know that bleeding was something that Patrick was looking at from the condition era. Does anyone remember what a condition era is versus a condition occurrence? So condition era versus a condition occurrence, that's the cumulative time in the observation period. So for your condition that you've observed, it's the actual cumulative amount of time. It's the era for that thing, right? Versus the condition occurrence is a single observation of that single thing. So eras and occurrences are just different things. One's point in time, one is a cumulative view. And it's okay if you've forgotten this. That was day one when you.
So the arrow will be like multiple, it could be multiple occurrence in an arrow.
Yes. But it.
Variable could be like categorically could be 1, 2, 3, 4 instead of just 0 and 1.
In,
It's just a span of time.
Oh, just a span of time like for the occurrence.
Yeah.
So if someone has a disease that always having that, so that would be like full length of our time error.
yep.
That would be like, so a condition error will be like the number from 0 to whatever time.
So it's just a start date to an end date? This is the duration of time that you have the disease, as opposed to each and every moment that you saw it coded.
And so in this case, the time period of ever never is in 30 days prior to the index and 0. That in this case, it's bleeding is the condition we're looking for. And so I point this out because I think as you're interpreting these different ever, never things, that can be a little confusing when you think of something that was the ever, never for a period of time. And we see, I'm trying to see, because you had mentioned you thought device. Actually, I think if I just click on device, it'll come. You said something interesting about device, which was you thought that maybe device exposures were something that you would want to be interested in because you know care patterns, right? And I see. Injection gadolinium-based magnetic resonance, probably imaging, right? It's probably a gadolinium-based MRI. We guess I'm going on a string that I can only see a partial of it. I don't think that was the device you had mentioned, right? You thought something else. So maybe the literature or our own a priori are not something we see in the plot. And why is that important? Because sometimes we want the data to show us things because we know or think that in practice these things occur quite frequently and they must have an impact on the clinical condition. But sometimes they aren't there. Sometimes we don't see the things we expect to see. Sometimes we see things we didn't know even existed based off the literature. And one of the things I think that Patrick was telling us about was about this interpretation of our values. And it's still very, very easy to look at your covariate table and to bring your clinical mindset and to say, I really think that these people are more likely to have this happen, so this must be a risk factor for that. But what's wrong about that statement? Does anyone remember what Patrick said about risk factors this morning? What did he say? Correlation is not causation. Correlation is not causation. It's an epidemiology joke, but the way we look at the information that we see in our covariate table, we have to keep reminding ourselves, even across data sets, little traps that we might fall into in interpretation, because it's very easy to want something to be a risk factor, because that's a word we say in clinical practice, but it's not really a thing that exists in this methodology that is truth, right? And so I'm going to pause for just a second because I'm meandering through plots, and I think it's very easy to be caught up in individual models, but what we are trying to do in a network study is compile multiple models that are the same clinical question in different settings and the variation at scale for that model. So maybe some settings it works, some it doesn't. In this case, both of my models with that particular people with, let's see, it was your endometrial cancer and your additional inclusion criteria. And then I made another model similar to Patrick's that was, I thought that hysterectomy, in addition to the endometrial cancer, would be more stringent. Does anyone have an opinion on whether that is more stringent? Just by looking at the AUC, did anything change about my accuracy, or my ability, I should say, my model's ability to discriminate for in this case, let's look at the two for the secondary malignant neoplasms of the lymph node. If this is your one, Bonnie, and that's Patrick's suggestion that maybe we're more specific, do we see any differences in my data? I know it's pretty hard to see. I can read it to you. One says 0.8124, and one says 0.720015. Yeah? And we see the O, it's about 5.6% for secondary malignant neoplasm of the lymph node, and it's 2.809 for same O, just more stringent T. As a clinician, when you're interacting with your patients, how do you feel like you would interpret this? Is 0.9 going to change your life? Going to change your clinical practice? I'm not a clinician, so I'm really asking because there are a lot of debates, right? Is that good, bad? It could be. So actually, I'm leading the witness here. When you're writing your results, it's really easy to interpret your AUC and to add some weight and say 0.9 or 0.09. We made a huge improvement in the model by being less stringent or more stringent. We went down 0.09. But holistically, we don't really know, actually, from looking at this view, if that's enough. I only actually have my data and Patrick's data. I actually probably need more data across the network to actually scrutinize, does this model work in certain settings? And so individually, we'll go through the exercises of scrutinizing the model by each contributing data set. But we ultimately want to get to a point where we feel in what settings and in what context does this prediction model work, and what are its limitations if not? And in claims data, especially from similar US contributing sites, it may be very similar. We might see our point estimates perform relatively similarly. If I could run this on a Chinese data set, I might see something completely different. And that's okay. It's actually completely okay to have your model not perform well in some settings and be better in others, because what we're doing is asking for the whole world of possibilities to go in, not just our cherry picking of variables. Does cherry picking, does that translate? Like individually selecting the things you think are most important. And so the hardest part of getting to your interpretation of results is you will spend hours and hours and hours scrutinizing, did I set up my T correctly? Because what I see in the output of the model, is that clinically useful? Are there things in here that are too similar to, maybe I didn't do a good job of getting rid of things that would get the machine to have a better prediction because it's basically the disease, but with not the same code. That happens a lot. And so this question of the day zero, how do we build time? And the idea of, do we get a procedure code in addition to the diagnosis code will come up a lot. And it's a balancing act of, ultimately, a literature review would help you figure out how are things performing today? How is the current standard of care? What are gains to be had? What is the percentage incidence for the different populations? And then you get to a point where you say, real world data is awesome and it's hard to interpret. And every point estimate I get when I run a model is going to be at the discretion of my view and my co-author's view. And we might have differing opinions. People might say, this is bad data, this is good data. I do not want you to walk away from this class saying, I'm gonna look at a PLP viewer and I know for sure this is a better model than that model. That's not the point of an AUC, and that's not the point of running these. What's more important is if you understand who did you pull into your analysis and what was their time at risk for developing that outcome, and what do we know about what is and isn't captured in this particular data set. So when you run an external validation, you might receive a model and its best predictors are just things that you would never capture in your data, like they're just not part of your standard source system. And that'll happen a lot. So your model might look like it has really low performance in that data, but it just means that a predictor that is really clinically meaningful just isn't something that you see in your particular site. So I'm gonna pause there for a second. I know we're kind of getting into the political piece of results interpretation. And I'm not sure, Patrick, if you want me to click through more, but I want to kind of, because we're at the results writing phase, so now comes the hard part, Bonnie. We have to turn this into something like that. We have to take that manuscript and then fine tune it. What are questions that you have for us if you were picking this up and going forward? And Jing too, and other people. So what would you need to know as an investigator to be able to continue to write that paper?
I want to know how could we find out what's the most important thing we could estimate in our paper, because we have a lot of data. How can we choose the one?
And when you say the most important, do you mean because you want to ultimately get down to a small model of not 200, or I have to look to see what's in this one. Let's see, we have, it's processing. We have, it's like 3,893 covariates, but not all of them have values. You can actually download this and be able to look at it as it's CSV. So I'd probably start with, so it's a little easier in the Excel view, I think, than sometimes, but you could actually go through here as a clinician and look through the top. There's a lot of text here. So what you want to do is we maybe filter down. I could filter this to only be above a certain threshold, because some of these are pretty small as we get to the bottom, right? They're little. You might spend some time and pick, the top 20 covariate values that are in, or maybe top 50, and do a literature review and say, is there anything in the current body of research, other cohort studies, that suggests this is something expected, because we already know from a small investigation that this is something that has been observed. And maybe that's the best you get to, is an assessment to say, we found in this model, there are 5 things that I can't find a paper on anywhere, but maybe they are worth a future investigation. Maybe it's helpful to know that, well, it looks like abdominal mass comes up a few times. Maybe there's something in here that makes a lot of sense, and maybe the reason it doesn't exist in the literature is because it goes by something else. It has another clinical name. Like I heard malignant neoplasm of the lymph nodes. There's a way that it's articulated, like our investigator had said something. How did he say it? Lymphatic metastases? Do you remember so the certain clinical terms in one clinical group mean something to everyone, and then outside of that clinical group, they're like, what does that mean? So we could be very well in the literature saying a synonym for another very common clinical term. Like we could find something here, then you call it something else in your clinical practice. And I don't even know that, because I'm just looking at the raw results and I'm not a clinician. But what I'm trying to say is the data itself is probably not going to tell you that 12 of these things are synonyms for something that's very commonly known as whatever. But when you're writing your paper, you might see that as you're filtering through the table, and you say, oh, these are all things related to this concept of abdominal mass pain or something, right? Does that make sense? And I regularly am asking clinicians when I'm writing papers with them, how do I roll these up into something that is meaningful and useful from a clinical point of view? Because maybe individually the clinical observation alone is like, you're like, no one would call it that. That's not really, but is there something else that it looks like? And so as you're writing your results, you'll probably use a table, the model table. You'll probably spend some time thinking thoughtfully about, are there things about the way I define the T that may have biased it to find the O? And it's okay, you don't always have to rerun your paper. It's okay to just say, I could have done a better job of designing T to not have insert whatever it is. So maybe day 0, I could have done a better job of getting rid of that other code. Doesn't mean you couldn't rerun it, but there are times when it's perfectly okay to report as is and say, results here suggest we should do another study that is more strict or not. What other questions do you have for how you would turn this into a paper? Do you ever have trouble finding a journal to pick to publish in? Yeah, I do too. So I'm going to show you a secret power of the OHDSI community. So let's say you get to a point where you like your manuscript, or you're somewhere in the middle of editing it, but you're like, shoot, I don't even know what clinical journal I could put this to. So what's our clinical question? Remind me. It's So if you had a full abstract, you could paste it here, but I'm just going to paste your question. So what am I looking at? So Jane is a tool that Patrick's team actually designed and has made freely available for people to utilize as they're trying to figure out how does my topic relate to other topics that have already been published on. And what's really cool about it is you can paste your abstract, paste your question, and it's going to suggest journals that may be already published content similar to what you're studying. And most importantly, I learned this one the other day, you can actually click on Show Articles, and it'll give you examples of other articles that are like your question. And what you want to do is read them as you have time and figure out a little bit about what was presented in that article and get a feel for, was the data similar to what I used? Is there something, maybe it can even be a reference for your paper, maybe there's some existing model. And what's interesting about this is that you could certainly do a literature search on PubMed, but this in particular helps guide you to other things to consider when you're publishing and to maybe find and head towards a journal that you think, wow, this particular publication seems to be really interested in improving the lives of women with endometrial cancer. And you know what, it looks like there's been a couple of publications, but this would be a great place to put this because clinicians in this audience are really interested in this message. So that's kind of what Jane is good for. It can help you figure out how to pick a target once you get to a good place with your manuscript. And I would caution, start with the end in mind. So now that you have a paper, or we'll run the model at more sites, you'll get back more point estimates. Knowing where you're going makes writing the paper a little easier because every journal has different stylistic preferences, they have different types of ways that they like to see information presented, and so it'll save you more time. And look, there's actually a Chinese Journal of Oncology here, so maybe the Chinese Journal of Oncology is a good target. I have no idea. Are any of you familiar with this journal? I don't know if this is like a funny translation. Yeah, looks like there's a Polish gynecology journal too, so maybe that's a good target. You know, we're all fluent in Polish now. But it's a good place to go because often when you're writing your own paper, you might feel alone and like you have no idea. This is freely available. You can update your abstract, and it'll give you different hits. And so the little scale over here says, based off your question, this is how confident I am. And I wouldn't worry too much about the influence factor so much as the appropriateness of the journal, because there will be some journals that are just not a good target for your type of question you're doing, and that's okay. There are tons of other options of where you can go. Looks like there's actually another Chinese journal in here too. So it looks like you have at least 2 Chinese journals if you want to write an article for them. And then there's a bunch of other gynecology journals as well. It's kind of cool. I have no idea which one you're going to pick, but we'll help you. And that's a big piece of it. So hopefully if I go back, my environment is still open. Does anyone want to try to test drive this on their own and show the class what they learned? Anyone interested in, you can play with the Shiny app in front of everyone. Does anyone want to do that? No, everyone's scared. I'm scared. Does anyone want to come up here and try to find something in the data? I can't take it off the machine and give it to you at your computer, so we have to do it together. But does anybody want to play with the PLP viewer? Yeah, you can come up. This isn't meant to be scary. This is the fun part.
So what does PLP stand for?
It's a good question. PLP is patient level prediction, and you'll hear it a lot when we say prediction questions. Almost everybody who speaks OHDSI just hears PLP because it's the package and the methodology. Now its sister is something we call PLE. Does anyone want to guess what PLE is? Population level estimation. Yep, exactly. And those are what kind of question?
Causation.
Yes. And there isn't some cute acronym for characterization. That's just still characterization. If you want to come up with one, that can be your OHDSI contribution. But yeah, so this is just my data. We could always pull back Patrick's data too.
So I can just click this to rank them.
Yep, so it'll filter, exactly. So these toggle based off of the high and low. So the arrow will tell you what direction is going in. And then each of these represents, the analysis column basically just says, for different combinations of how we configured the prediction method when we were doing that this morning, those are just different sets of outputs.
If I want to click in, type in.
Yep, and then so if you select a model, then you might want to go to a different tab. You can look at the performance, you can look at the model. So this will give you your ROC. And when you click it, do you know what it's doing?
No.
So it's going to adjust to that exact, basically, so if you're picking a spot on the ROC plot and saying, I want to know what the precision recall is for this specific sensitivity and specificity. So it's like 0.48, but it's like yeah, 0.48 specificity, but like 92% sensitive. So you're looking kind of at the trade-offs of your recall plot relative to that selection. And so it's dynamic, so every time you picked something else over here, I don't know if it's going to look dramatically different, but you could update and make it angry. But it usually will do that. And so the Shiny app is really cool as a thing because when you work with investigators, they can't share their data, right? Patient level data has to stay where it lives. I can send you my PLP output. You can save this. We can put this on a server. You could scrutinize this. You could look at this to your heart's content. It's all results files. It's not anything. I don't see the patient records. I can't see the database itself. But that means I might ask questions. What kinds of patients end up in your care system? What, you might do other diagnostics, like characterizing the contributing data sets, because maybe you see something and you don't know why, but maybe you have a hunch that it's because the data is showing some care artifact, right?
What does this mean, this box plot?
So the box plots for predictability by class, this is it your type 1 and type 2?
It's the same thing as the probability distribution, just on its side.
Ah,
The blue box is your people who don't have the outcome, and the red box is the people who do have the outcome.
and then if we look down below, the same color scheme, so this is the same thing, so no outcome. They're the same, so across plots, it's the same color scheme. So no outcome, outcome, same thing, no outcome, outcome, and this is based off of the threshold that we're setting. How, basically it's that decision point. Do I want to be more sensitive or specific? And what does that do to how I see false positives and true? I can never say it without tongue twisting. If I would see true cases versus misclassified cases. And why is this really important? When you're interpreting your results, you may have people who overstate because real world data, observational data is flawed and not the clinical trial standard. They might say, you're doing a really bad job of classifying cases. And you could say, no, I'm not. I know exactly what the threshold here is. And I know that X percentage are going to be misclassified. But I also think that that's acceptable based off of all the other places on the plot that I could have picked, right?
I want to try. This one is the marble.
Yeah, so and the hardest part about, and the box is a little bit better. It's just some of the hovers are a little constricted on this screen. That's why I was saying, I don't know exactly what this, I think this is,
Immunohistochemistry. This is
So it's a measurement for, it looks like it's probably,
For
neg-
diagnose.
yeah, it looks like negative maybe 30 days relative to index, or maybe it's,
Yeah, they will pick up some tissue and they do some chemical examination, so they can know whether they had this kind of metastasis.
exactly. And so maybe that is something that has some, it makes sense it would have more prevalence in the persons with the outcome than without, because if secondary malignant neoplasms, you're probably maybe likely to get a tissue sample of, I guess, of your lymph, right?
So if we got this kind of data, we can interpret it in our paper.
Yep, you could pick some points in here that you say, so you could either do it through the plot, or you could use obviously the tabular view. You could say, as a clinician, this makes sense because, as you said, tissue samples are commonly ordered in this group or that group, and maybe I don't know, we have to type in the value for that one. Was it immuno? We'll see if we can find it. Its full name, whoops. See if we can find, I'll try a short name. So let's see. See these, that's why some of these don't, these are measurements. Let me make this a little bigger for you. So I might say, and we have to see what the value is, but you might find things that, these look pretty small. This is immunoassay. Oh, that's a good idea. Okay, so these are the, whoops. Trigger happy. Yeah, this is it. So let's see, measurement during negative 30 through 0 days relative to index. So that's your index in this case for your T is, do you remember?
Yeah.
It's your endometrial cancer and your additional criteria. So it's that single antibody stain procedure has a higher value than some of the other measurements, which you said is probably makes sense because it's an artifact of people who get this outcome are more likely to have that type of clinical interaction. So that's exactly what kind of this up and down between your plot is interpreting some of the things that the model says may be indicative of the outcome. Some of these are maybe indirect ways of seeing your outcome, and then you have to decide, do I go back and control for them because it's, that's the synonym thing. It's actually kind of like having the outcome and I didn't control for, maybe in the design I should have done a better job for that synonym. But this case, I think this is pretty regular, right? You said there's 3 different ways that we see that shows up in the data. So these are different, probably different types of, and different types of, yep, so this is anytime, and this is probably just a different type of initial antibody stain as a thing. I can't see, this is an additional one in addition to the initial one, so maybe this is they needed more tissue stained, I guess. Maybe. I don't take tissue samples, so but yeah, go ahead, keep going.
There's another thing is how to integrate this value to that means those 2 are valuable for us.
What do you think? Do you remember at all on some of the guidance Patrick gave us about positive or negative or 0?
I remember he said if this one was 0, it doesn't mean this doesn't mean anything to us, but means maybe we didn't use this kind of data, but it can be useful when we see this value. But I just don't know because I just learned the p-value in statistics, but I don't know.
Yep.
What does this mean? Is there any relationships between those 2, or is this just another figure?
It's not a p-value, but it's a good question. You hear all these terms and statistics, and I know a lot of you are not statisticians.
Yes.
This is in relation to the model that you put into this machine, I don't know where Patrick's I guess that's the black box over there, right? Looks a bit like a charger, it's weird. So in your black box, you throw all these clinical attributes, and the box does all its processing, and it spits back out little values, coefficients related to how it sees that thing in relation to all the things you gave it. And so while 0 doesn't mean anything, and some of these are not really, this isn't a magnitude. It's saying it may be worth thinking about that this is something, if you were making a small model, this may be something that has a disproportionate relationship with the T and the O. And it tells you a little bit about people who have the outcome versus those who don't. What's the frequency of, or the mean in this case. But you're right, it's not a p-value. So p-value is, does anyone know what a p-value is? Yeah. Anyone want to tell the class what they think a p-value is?
Well, just to
Yeah.
go back to helping to understand that value column. If you remember the example of the CHADS2 score, where it said if you have a hypertension, if you have heart failure, you get a score of 1. If you have hypertension, you get a score of 1. If you have a stroke, you have a score of 2. Those scores, 1 and 1 and 1 and 1 and 2, those are the values.
Yep.
Oh, I got
So
that.
the way to think about this is if you have a procedure with a procedure focus, that top one,
Yes.
you get a score of 1.14.
Oh.
And if you have a neoplasm of the endometrium, you get a score of 0.83. And if you have whatever the next one is, you get a 0.72. So that's the score that you add up a bit based on you having those things. And when you add them up, there's a way to turn that into the predicted probability.
So if we can find out maybe 3 or 5 this kind of thing that can add value to our clinical use, so we can just create such a trust to get
Yeah, so
implemented in that.
if you are interested in trying to create a simple model like the CHADS2,
Yes.
then you could use this approach as a way to find which variables you might want to put into your simple model. And then you could evaluate how does the simple model compare to this optimal model that is very big.
And as you get better at it, you might look at these things and say, why is that? Why do people get a 0.83 for neoplasm endometrium? Didn't I make them all have endometrial cancer to be in the study? You might, and that's where you may say, we might look up this condition era and see, this doesn't mean much to me because it's something about the construction of the question that is just an artifact. And that is why you have to think about it big picture. So there are a lot of values here. Some are very small, so you may decide they have no, in theory, they don't have a lot of influence on that small view of it, but you never know. If you have to look through them and say, perhaps, and that's where you could say in the literature, cytopenia is really common, and then we may look into and see, oh, but it's only in, and maybe there's something about our T construct that excluded the people who are more likely to have that. All of that is the fun part of interpreting all of the different clinical attributes we observe. You could have a nuclear cataract, hypertrophy of the uterus. Some of these things sound terrible. What else would be helpful to walk through again? What are other sections or other things that? Because I will say you'll spend a ton of time in this table and this plot when you're doing the interpretation and the literature review afterwards for your discussion. I spent a lot of time on this section.
Yeah. And also how to combine those several statistics, the several outcomes from other databases together.
Yep. So I'll show you, not for our study because we don't have it done, but I'll show you what that looks like. Go to data.odyssey.org. This is a bunch of Odyssey studies. I'm sure there's one published here. Yeah, so let's say, And this is when we did, I think this is our study from last year, right? So this is just an index of other OHDSI network studies, and people publish some stuff. When somebody runs the study and they generate this file, like I did and Patrick did, we can actually merge them, and then we can filter by the database name. So we can actually see all of them in one place. So I could change, let's say I just pick one cohort. And I say I use this as my validation. So I did my internal, actually. So I have different databases here. And what we'll do is we collapse all of the network sites that participate. And they each will have their own name. And the people from each of these databases will help you as you write your study, because they can give you information on baseline characteristics of their database, maybe information about the number of years of coverage or the male-female split. And this is, it's all the same thing, which you'll notice are just different contributing sites. And then we take this and we turn them into sometimes much smaller tables where we just show the AUC by database, and we indicate which database was so in this case, the internal validation was this one database, and this is the external validation from other databases.
Skipped over because it's an advanced feature, but when we selected the covariates to pick, one of the things you can do is you can actually just say which specific covariates to include or exclude. So what you would do is you would create a concept set that contained the 5 things you wanted, and you would just only include those.
So those are concepts. We can create.
Those are concepts. You create a concept set that would contain the 5 things you want, and then you would pass those in as the variables to use. The time is defined by which of the variables you choose. So you'd be basically choosing conditions all time prior, but then you would say, I only want intracranial hemorrhage. And that would get you the one variable you're asking for.
Yep.
And then the second question I have is, I'm just wondering, because we talked about chance a lot, it picked like 5 variables, and then it's not great, but it's better than guessing. So like for your prior study you've done, like have you tried like some simple models that actually work pretty well?
Yeah, so I had it's not published yet, but we had, okay, just explain what happened. So we did a prediction problem where we predicted an outcome, and we got an AUC of 0.82 using a full model, but it included like 300 variables, and our clinicians didn't like that. So we made a model that basically uses 8 variables, and just like the Chads 2, we gave them scores, and it got us an AUC of like 0.78. So it's pretty good compared to the overall model. So then our work is summarizing the simple model, and we say the simple model isn't optimal, but it's pretty good, but you can use it by counting on your fingers. So therefore, people might want to use it.
So you give like integer scores for like
integer scores for each of the categories.
Yep.
Eight of the 8 covariates.
That's right.
Okay, and the covariates are the stuff like the doctor would know.
Exactly.
Yep.
They're kind of asking the question, like, does the person have this disease or this drug or whatever? So that way they're easy questions to ask.
And that's where the clinician looking through the list, you and your expertise, you say, oh, I know what that means. Here's a simpler way. You said, oh, tissue sample, and it was something very long and not that. That's exactly what isn't in the output is the synonym to layman or normal, term. And it all depends on sort of what you think is relevant. And there may be things that They don't have a simpler term. You're like, no, everyone calls it that, and that's fine. But it'll be a balance too of trying to decide the right intent of what you're doing. If you're simply writing a paper for the sake of saying, we have not done a good job of characterizing this disease and this outcome, and the literature has some gaps, and I would like to build a model to better understand all of the things that could contribute to developing this outcome, that's perfectly fine too. You don't necessarily have to make the small model, but many people are working towards taking big models and bring it to point of care. But it's a long journey, right?
Yes.
You might have many papers in that journey, many models you build. So this one's a big one, but when you collapse all the data sets together, you will also have the cumulative view of the covariates for the internal validation set. And I believe, well, I don't see it in this view, but you can see covariate values by data set when you export it. This one is a little different than the one we generated, but we can actually see relative importance because, again, like we said, care patterns may influence how we see things. And so that's where we said maybe one data set doesn't have it and others do. We might learn things about the way these people are treated based off of something we see in the covariates. So we're almost done. So you've gotten to the hard part and you've survived. You generated a file. It was really scary and there's still a ton of stuff in it you don't understand, and that's okay. What do you do to continue your OHDSI journey? Well, for one, you start going to the OHDSI forums and maybe engaging. In fact, if you go on the OHDSI forum today, this is optional homework for all of you. I highly encourage you, when it loads, see this first pin here? Welcome to OHDSI. Introduce yourself. Say hello. My name is whatever your name is. Hello, my name is Kristin, and I do this. Actually, this is not the intro to OHDSI. This is, oh, somebody posted OHDSI in China. I saw you. Introduce yourself. Here you go. Introduce yourself. Tell us what you're interested in. And it's crazy. People will come out of the woodwork and say, hello, I'm working on this. Would you like to join me? And in the case of your paper, we will help you put this somewhere so other sites can look at the package and run it. Look, I think I know this guy. Have you guys met this guy? He looks familiar.
Yes.
But introduce yourself. Start your OHDSI journey there. And if you're totally overwhelmed with all the information, the book of OHDSI is a great resource to go back and as you digest this and take it in, read in increments some of the concepts we've covered in the last few days. And there are videos that'll be published. And I have a feeling there'll be more meetings in China happening soon, so you can keep on the OHDSI in China website and look for those gatherings. So we should all give Bonnie a round of applause. She's been a great investigator, as are all of you. Who's excited to join the journey? Yeah. And you don't have to stay here past the time just to hang out because we're cool, but if you have other questions or other thoughts, we're available to chat. And get excited. There is a whole world of methods available to you, free code on GitHub that you can play with. Even if you don't have data, the patient level prediction package that we walked through today, this chapter will walk you through it, but there's actually, you can make there's a test data set that you can generate when you do the install guide. There's fake data that you can play with. And you can start to design protocols even without having your own data to touch. And that's the cool part. So, yay. And you're all still awake, so that's good. Awesome. Thank you, Bonnie.
Thank you so much.
And thank you all.